Okay, well, we are right at 1:10, so I will move on to our next speaker, Dr. Jone. She is a professor of pediatric cardiology. Dr. Jone's clinical and research interests are in 3D echocardiography, echocardiography quality improvement, tele-echo, which is really interesting, and Kawasaki disease. She's the principal investigator for a 3D echo multi-centered trial and PI for a National Echo Quality Collaborative. And she's also, importantly for this project, or for this talk, the site PI for an NIH-funded clinical trials on multisystemic inflammatory syndrome in children with COVID, as well as Kawasaki disease. So I will turn it over to Dr. Jone.
Thank you very much, Kristen and Dr. Sokol, for inviting me to give this talk. I think Kristen did a great job in giving the overview of PASC, but I'm going to focus mostly on the heart and what are the effects of COVID on the heart. And I think later on, as you'll see, the mechanism of cardiovascular injury, and then probably in the long-term follow-up of these COVID patients, will eventually fall in the long-haul COVID clinics. So no disclosures. So this is a general outline of our discussion today. I'm going to talk about cardiovascular complications of the COVID in adults, and then quickly shift over to multi-system inflammatory syndrome in the adults and children. I think the long-haul COVID patients, when they experience chest pain, dyspnea, or tachycardia, may be related to the cardiovascular injury that occurred in the acute COVID. So the potential mechanisms that came out in 2020, when the adult cardiologists are looking at these patients, some of the cardiomyocyte injury occur when you have a response to a severe inflammation, like cytokine storm, viral direct invasion of the cardiomyocyte resulting in cellular damage, and then ischemic injury in the presence of severe hypoxia as a result of acute lung injury. So the complications are usually myocarditis. So you have a direct injury of the myocardium itself, acute MI, heart failure, cardiomyopathy, arrhythmias, shock, and cardiac arrest. And venous thromboembolic events are actually quite high. So when looking at the literature on cardiovascular complication of the adults, arrhythmias were reported about 5.9 to 16%. Initially, it was related to hydroxychloroquine and erythromycin that were given to these patients, and they caused prolonged QT. And then one interesting mechanism is the hypokalemia that occurs in these patients when the virus invades the cells. It binds to the ACE2 receptors and it increases the ACE2 receptor. Therefore, you have increased urinary excretion of potassium. So you become hypokalemic and then developed arrhythmia problems. Acute coronary syndrome with plaque destabilization can occur. Myocarditis was reported in a third of the patient and contribute to about 7% of the deaths. Heart failure were in 23% of the patient. Thrombotic events, the Italian studies reported 7.7% of the patient who had thrombotic events that were hospitalized, and then 31% in the ICU patients. Most of them were DVT, and some of them were pulmonary embolism that resulted in RV dysfunction. Cardiogenic shock accounted for 83% of the deaths that occurred in the early series of the COVID patients. 12 to 20% of the hospital patients have cardiac injury, and they were found to have increased troponin release in their blood. The recent study done by this group was actually quite a nice summary of the mechanism of the cardiovascular injury and the complications after COVID. And of course, if you have the risk of obesity, hypertension, your older age, diabetes, if you have cardiovascular disease already, immobility and critical illness and chronic respiratory illness led you to have more complications in cardiovascular injury. So systemic inflammation resulted in thromboembolism. They studied prevalence of these patients 81%. And then a subsequent study looking at 8,000 patients, the mortality was about 23%. And the acute coronary syndrome in 4,000 patients in a different study where they looked at these patients and the mortality was 27%. Now, if you look at the direct viral injury of the myocyte causing myocarditis, the prevalence was 36% in 2,000 patients. The mortality was about 60%. And then heart failure, cardiomyopathy, 191 patients, the prevalence was 29% and mortality were 47%. And then if you had a COVID drug induced side effects resulting in arrhythmias, they studied looking at 138 patients, 17% had prevalence of arrhythmias, and the mortality of arrhythmias in the 17,000 patients was 20%. So this paper had a really nice summary of all the mechanisms of cardiovascular injury and what could potentially occur in these patients. So looking at long COVID literature, there's not many, as Kristen had said. In the acute COVID with palpitations, arrhythmias, 17%. With the long COVID patients, it was 11.2%. If you had chest pain, some of them at the end, after they recover, still complained about chest pain, 12.3%. And then myocarditis was about 27%, and shortness of breath was about 26%. So not very much different from the initial presentation of COVID. So PASC occurred in 4 to 6 weeks or greater than 12 weeks after COVID. Some of the literature, I don't think they've decided on which date yet. But if you look at the cardiac MRI studies, there's myocardial edema and late gadolinium enhancement observed in 50% of the 26 Chinese patients that presented with long COVID cardiac symptoms. And then another study looked at the myocarditis pattern that was observed a month post-infection, and that occurred in about 27% of the 148 patients in the UK study who had myocardial injury. And then later, a third of them found them to have consistent symptoms of active myocarditis. And then the last study which came from Germany was 78% of the 100 mild COVID cases in Germany, despite having fewer comorbidities, had cardiac MRI abnormality of similar extent and severity to that of the patient who required hospitalization. So in the myocarditis, what they found was that there's these late gadolinium enhancements, but people really don't understand if you had that enhancement and if you had no symptoms, then what do you do about that? So these are still kind of the answers that we're still looking for, and hopefully we'll find as we study more on these patients. So then I know Kristen talked about PASC is not multi-system inflammatory syndrome. However, I think in the pediatric population, this is something we have to keep in mind and follow these patients over time for the long term, because as you saw, the acute COVID, they cause myocarditis, and you need to follow them long term to see what's happening to their heart. So I'm going to quickly, the CDC definition has come out, and most of these features of MISA or MIC are patients who come in with no alternative diagnosis. They have to have fever while they're in the hospital. And then the presenting clinical symptoms is rash, red eyes, and then cardiovascular dysfunction, and some of the secondary clinical criteria with the neurological symptoms, shock, hypotension, abdominal pain, thrombocytopenia. As we talked about what's going to happen in children, abdominal symptoms are going to be the most presenting sign. And they have inflammation, very high inflammation, and association with the SARS-CoV-2 infection. So let's quickly go into multi-system inflammatory syndrome in children. As you can see, the red here, they have cardiovascular dysfunction with coronary artery dilation or aneurysms. They have the Kawasaki stigmata. So what is Kawasaki disease? They have the red eyes, high fever for about 5 days, the rash in the hands and feet, the red cracked lips. So initially, when patients after they had COVID presented with similar symptoms to Kawasaki disease, this is how we started noticing the similarities between the patients. However, as we continue to talk about, there are differences that's going to happen to these patients. So the European came out with their diagnostic criteria, so did the CDC and the World Health Organization. As you can see, most of these children are less than 21 years of age. Some of them limit them up to 19. They have to have persistent fevers. Some say 3 days, some say 24 hours. They have to have multi-organ system that's affected. So if you have the heart and the GI system affected or the lung system affected, you have to have these organs are involved. Coagulopathy is another system that's involved, and they have to have high degree of inflammation. What we notice, these patients will have very high CRPs and lymphopenia. They're both in the definition of the European and the CDC and the World Health Organization, and they have to have some sort of SARS antibodies or PCR positivity, or have a likely contact with COVID patients. The exclusion means that you have no alternative diagnosis for these patients. So let's look at the prevalence or the reported cases now. This is tracked from the CDC website since May of 2020 up to June. There's about 44,000 cases, and there's reported 37 cases that are dead. And the MISC children tend to follow the peak of COVID. If you look at the peak of COVID infection, the MISC will follow about 2 to 5 weeks after the peak of COVID infection. And the race and ethnicity, as people reported this morning, one of the speakers talked about there's a disparity between these children who were affected, and most of the kids are Hispanic and Black population. And the median age group are around 9 years of age in these children, and half of the MISC children are between 5 to 13 years, and 60% of the children were reported to be male. So this recent study that came out in July, actually August 1st, was a really nice study on the MISC children, how they present, and what is the demographic and treatment analysis of these patients. So they studied 1,700 patients. And if you look, 60% of the patients are male. So, and then the race, as we said, Hispanic and Black children are higher compared to the white and Asian population. And then they have preceding COVID-like illness, only 24% of the time. Now, here in our hospital, we check COVID antibodies, and if they're positive, then these patients, and if they have clinical criteria of MISC, we treat them. And if you look at the symptoms and signs that present, abdominal pain is probably the highest presentation. Vomiting, diarrhea, so the GI presentation is actually quite a lot with rash and red eyes. We see a lot of the children. We have seen about 108 in Colorado now. And then ICU admission is about 60% of these patients. And cardiovascular findings, if you look at hypotension and shock, so 50% of the patient will present with hypotension, shock 36% of the time, and then cardiac dysfunction with myocarditis, coronary artery dilation, and pericardial effusion. These are a lot of the clinical findings that we see in MISC patients. So this study summarized that the MISC children will present 2 to 5 weeks after COVID. In the 18 to 20 age group, they can present as early as 7 days. GI symptoms are the highest presentation, rash and red eyes, hypotension and shock with 60% admitted to the ICU. 0 to 4 years of age have fewer complications, less ICU admission. Myocarditis, cardiac dysfunction, and coronary artery dilation can occur up to 30% of the patients. And when last year, when people were reporting about MIC in children, there were different studies from different centers. And as you can see, some reported higher LV dysfunction than other studies. And then some reported higher coronary abnormalities than other studies. But I think the Belay study summarized 1,000 patients. Those are the clinical features that we mostly see now in our patient population. So the distinction between MIC and KD, and it's actually quite obvious now because in Kawasaki children, they're less than 5 years of age, and the MIC children are older, and they're mostly in the Black and Hispanic population. However, Kawasaki is mostly in the Asian population. GI presentation in the Kawasaki patient are less common, but in the MIC children, they're very common. Shock in KD is only 5%, but in MIC, they present 60% of our population. And their CRP are probably triple the time, the side, like CRP, it will be like triple the rate of the Kawasaki patients. The absolute lymphocytes and platelet counts are very low in the MIC children compared to the Kawasaki children. So what's the pathophysiology? People think that MIC is related to the hyperinflammatory response. There's cell studies looking at T cells and B cells, and they've also found that TNF alpha is very high with IL-6 being very high in these MIC children compared to the Kawasaki patients. Some people think that they're cytokine storms, macrophage activating syndrome, and they appear very distinct from the Kawasaki patients. So what are the treatments for our MIC patients? So in the Belay study, people mostly gave IVIG because when these children presented in the UK and in New York, they had features of Kawasaki like patients. So we treated them with IVIG and they worked, and some patients needed some steroids. And then other people treated with infliximab, and I'll talk about our Denver experience with infliximab. Most of the patients are on aspirin. We are debating whether these patients needs to be on aspirin or not. Let's look at the Overcoming COVID study that was recently published in the MIC population and what their initial therapy was in July of this year. So this study is very interesting. They looked at the initial treatment with IVIG and IVIG plus steroids, and there are 58 centers around the US that are participating, and 518 patients were MIC children. Their primary outcome was looking at LV dysfunction or shock needing vasopressin on or after day 2. The secondary outcome is similar to the primary outcome. However, they also looked at if the patient needed additional therapy or if they continue to have fever after day 2. If you look at the graph over here, they did a propensity score in both groups. So IVIG and IVIG with steroids. And the outcome of the study came out that the initial treatment with IVIG, and steroid was associated with lower risk of new or persistent cardiovascular dysfunction compared to the IVIG alone. And they require less additional therapy. However, the fever and ICU stays were not lower in these populations. And so then we looked at another study also released in the New England Journal of Medicine in July at the same time. Is called the BATS, the Best Available Treatment Study. And in this study, they looked at 32 countries with 614 MIC patients. It's IVIG versus IVIG plus steroids versus steroids. Their primary outcome was looking at inotropic support or mechanical ventilation by day 2 or later, or death. The secondary outcome was reduction in disease severity on by day 2, or treatment escalation, or the time until reduction in organ failure and inflammation. So now if you look at these patients, originally 651 patients were enrolled and 614 patients met the inclusion criteria. So you can see that 246 patients had IVIG, 208 had IVIG plus steroids, and then 99 received steroids alone. So in their results, IVIG versus steroid, they did not find any difference in the primary or the secondary outcome. And then IVIG versus steroid, they did not find any difference in their primary or secondary outcome. So the question was, well, these are big studies between IVIG and steroids. One study said, if you treat it with IVIG plus steroids, then the resolution of symptoms, the need for adjunctive therapy was less compared to the other study. And I think that these two different studies are designed a little bit different and different population. So what about our Denver study? We have been using infliximab for our coronary artery dilation in Kawasaki patients. And so we thought, since the immunology studies have come out, looked at MIC children versus KD, the TNF alpha was much higher in our MIC population. So what we did was we did IVIG as initial therapy, and then we did IVIG plus infliximab in our patient population. So although our patient numbers were N of 52 in the dual therapy, compared to the initial therapy with 20 patients, we did find a difference that our IVIG plus infliximab patients were less likely to acquire additional therapy. They had decreased development of LV dysfunction. So their LV function improved quicker compared to the IVIG alone. And there's rapid decline of inflammation and decrease the ICU length of stay. Now, the study is under revision now, should be published pretty soon. So let's look at the outcomes of the MIC children. Most of them survived in the Belay study. There's 1.2% of the population that had MIC died. And this study was in the 2020 when they looked at MIC children, 662 patients, there was only 1.7% that had poor outcome with death. And then most of the cardiovascular abnormalities that we found were reported with LV dysfunction, coronary artery dilation. However, they all got better over time. There are currently many studies looking at the long-term outcome of MIC children and COVID children. So one of the ones that we are very involved in is the long-term outcomes after a multi-system inflammatory syndrome in children. It's the MUSIC study. We're looking at in the next 5 years what's going to happen to the heart of these children. They're getting echo studies, stress echoes, MRI studies, and then looking at them in the next 5 years. There are some pharmacokinetic studies that are being done, looking at COVID children and MIC children. There's some PRISM study done funded by the NIAID, looking at COVID patients, including MIC, to look at their immunologic pathway. And then caring for children with COVID. And lastly, the Overcoming COVID study is ongoing as well. And we are part of the Overcoming COVID. We are also participating in this last study called Prevail, which is using artificial intelligence to quickly diagnose MIC in children. So in summary, I don't really know what's going to happen to the COVID patients. However, with their cardiovascular complications that's occurred while they're having acute COVID, I think they need long-term follow-up in the adults. And then MISA is now recognized in the adults. We have taken care of one adult, at least for the time that I was taking care of MIC children. There was a patient over at the university that we took care of, and he's recovered. In the short term, the MIC children have all recovered at 6 weeks of their illness and recovery of their heart function. Their stress tests and stress echo have been normal at 3 months, and their cardiac MRIs have now all been normal here at Children's Hospital Colorado. The long-term effects probably require more studying into these children. So thank you very much. I'd like to thank the team at Children's Hospital Colorado, and thank you for the organizing committee for inviting me to talk about this. Happy to take any questions.
Thank you for that great talk. I think there's a couple of questions in the chat. Ron had initially asked how you exclude Kawasaki versus MIS-C, but I think you addressed that after he had asked the question. And then Dr. Jolly was wondering, should we be looking at cardiac MRI more commonly in our adult ICU patients that have persistent shock? Do you think that we might be underestimating MIC in adults?
So, I think the MRI will show up as late gadolinium enhancement showing edema and inflammation. And I think for all the COVID patients, that happens if they have evidence of myocarditis. So if the echo shows ventricular dysfunction, you will see evidence of inflammation in the MRI. I think that might be helpful if you guys are having trouble getting these patients out of the ICU with presenting with persistent hypotension. But I think the CDC criteria is very clear that if you have persistent hypotension, high inflammation, and you're about 7 days out or even 2 to 5 weeks out of COVID, and you can't get them turned around, the MISA, you need to consider that. I think in the university patient, that patient was really, really very ill. And then when they asked us, we treated a kid, well, he was 19 at the time, 20 now. We treated him with IVIG and he turned around quickly, and his coronaries were dilated in his echo. So we treated him with infliximab and he turned around quite fast. So that's something to consider if you're having trouble getting these patients better. Did the prior speaker this AM mention COX inhibitor use was associated with worse outcome in COVID? If not sure if aspirin was associated with worse outcome, any Reye syndrome. Yeah, so we have not seen Reye syndrome with low dose aspirin. All of our congenital heart disease patients, even the Fontaines in their 40s, they're on low dose aspirin. We have not seen Reye syndrome. Reye syndrome was reported when you're using high dose aspirin. So low dose aspirin does not occur, and I have not seen it, knock on wood, in a very long time. And then COX inhibitors. I think the pathway when the patients are on aspirin, we tend to ask the patient not to be on ibuprofen because it will inhibit the effect of aspirin. And mostly aspirin, the low dose aspirin is given is because these coronaries are dilated and we don't want to have them clot in their coronaries. Now, a lot of the MIC children present with thrombocytopenia. So if they have low platelets, less than 100,000, we tend to hold the aspirin because they're not clotting anyway. They're just trying to bleed. So those we hold on. So we have a pathway that's developed that if there are a certain number of platelets, then we don't give the aspirin.
Have you found that vaccination have you seen cases in patients that have been vaccinated?
So we have not seen MIC in vaccinated patients. However, we have seen myocarditis associated with vaccines in our teenagers now. We have seen about 12 teenagers after their first and second dose. And interestingly, they also showed inflammation in their heart with their MRI. However, their echo, some of them are normal, which is very scary. But they've all recovered. They've come back to our clinic now. They've all recovered. So.
Any
So-
other final questions?
Yeah, so just a follow up on that last comment about the children who were vaccinated and had myocarditis. Are you saying that it was the vaccine that caused the myocarditis, or that they also had a natural infection causing that?
They did not have the infection. So vaccine associated with myocarditis has now been reported as a hot topic right now in the pediatric and the young adults. And the recent paper came out that they have inflammation of their heart after their first and second dose of vaccine. However, that only occurs in 1 in 50,000 patients. But they do not have the illness. So we have sent PCRs on these children and they do not have the COVID infection. And they're actually well. They only present with severe crushing chest pain and high troponin leak. And they have no respiratory illness, they have no fever, they have nothing but just chest pain and troponin leak. 2 to 5 days after their vaccine. But a lot of the people are asking, well, then should we not give the vaccine? I don't think so, because MIS-C occurs in 1 in 3,000 children who have COVID. Vaccine associated with myocarditis occurs in 1 in 50,000. So I still think patients should get their vaccines, despite some of the children we're seeing have this myocarditis thing associated with COVID vaccine.
Thank you.
You're welcome.
Well, we are right at 1:40, which I think is our end time. So if there's no other questions, I think we will wrap this session up. And I believe we are wrapping up this session for the day.
Thank you, everyone.
Thank you, everyone.